Very good. So welcome to the first Future Leader Forum. So maybe before the start of our interview, I just briefly introduce to our audience what is the Future Leader Forum or this Interview the First Offer program about. So Interview the First Offer is part of a program we are running in China. We call it Chinese Ophthalmology Future Leader Program. So this is a program that we try to cultivate the future clinician scientists in China and also beyond, and try to make sure they inspire their interest on running clinical research program and try to solve or propose new solution for eye diseases. We got a theme program, we call it Interview the First Offer, which is select the most important publication scientific paper, and then we invite the first author or the senior author of the paper just to share how they run the study, why they come up with these research questions, and then more importantly to share the story behind behind this interviewer. So then we ask questions, and then we hopefully in 30 minutes time we just discuss all these anything about this paper or can be beyond the paper in a meaningful way. So today is very special. Our first section, we invite Professor Carly Lam and also Professor Chihoto from Polytechnic University, Hong Kong. They are the I think it's really the myopia control or myopia researcher, or also optometrist clinicians that I really be admiring for many years. So today we're going to discuss a little bit the two papers that they are running on the DIMS, Defocus Incorporated Multiple Segments Spectacle Lens. That's one paper published in 2019, and another one on a 3-year study published very recently in 2021. So I start from by asking the first question. So we understand you got 2 papers published on your interesting study on DIMS as a randomized control trial. So can you just briefly tell us what is the major or most important finding in these 2 DIMS paper? So I will have Kali to start with the Q&A, and then I have Chiho to supplement.
Yeah, sure. Thank you, Professor He. The first paper in 2019 was a 2 years randomized clinical trial. So we ran it as double mask. And so there are 2 groups of children. One group of children were wearing the DIMS lens, and the other group were wearing the single vision lens. And after 2 years, we found that the DIMS lens can retard myopia progression by about 60%. And likewise, it can reduce the axial length by 60%. So we follow up the children for a 3rd year. And in the 3rd year, we did not do it as a RCT, but as a follow-up after RCT. But we also found the similar changes in the myopia progression and axial length elongation. So we estimate the efficacy to be sustained in the 3rd year.
Yes, Chiho, anything to supplement in terms of the clinical significance and how important and why this study come up? I mean, the ideas.
Well, thank you, Professor He. Yes, as Carly was saying, it's important to see that it has a retardation effect using a principle that we found from the animal study. And we apply in the, first of all, in the contact lens to prove the principle. And then we want to popularize this technology so that more children can be benefited. I mean, contact lens is not for everyone, but spectacle lens will be a lot more easier to wear and so on. So we are really excited to see the incorporations of optical defocus in spectacle lens actually produce a very, very significant retardation effect, much the same way as the contact lens have shown. So we're happy that we can help people to control their myopia.
So I think before we actually have the results of the DIMS lens, there are already several different methods like uncorrected, the refractive error, and then using progressive addition lenses, bifocal lenses. And later on, there were a huge sort of research into the orthokeratology and other contact lenses. And there was another wave of atropine. So previously, when atropine was used, it was a high dosage, and it put people off because of a lot of side effects. But lately, they also found that using a lower dosage, atropine can also retard myopia progression, but to a lesser extent comparing to the high dosage. So it was through all this type of methods that we based on our animal research, and we identify myopic defocus can retard eye growth in animals, not just in chicks, but in mammals too. And therefore, we think of applying this concept to a spectacle lens. In the beginning, Professor To already mentioned, it was a contact lens first. But the principle is to use simultaneous vision, because in human, we cannot just apply the myopic defocus. We have to correct the refractive error so the child can see clearly. So it's a combination of a myopic defocus with refractive error correction.
Just as what Kylie already mentioned, there's an optical method, optical way, and also pharmacological way to control myopia progression. So when you put DIMS and compare DIMS with, for example, low dose atropine treatment. So my question is really, because in your clinical randomized control trial, you put single vision spectacle correction as like a placebo, or not really placebo. It's like a blank, no treatment control.
No treatment.
Yeah, no treatment. So theoretically, if we wanted to prove the efficacy of myopia control, should compare with existing product or solution in the market. So why you didn't think about to compare the DIMS efficacy with, for example, low dose atropine or orthokeratology?
Our idea of doing the RCT, we really want to prove that myopic defocus simultaneously working with a refractive correction is as good. So that's why we did not mix it with any other treatment. But again, lately, there are a lot of combined treatment research going on. So there have been atropine combined with ortho-K. And in our school, we are also running atropine combined with DIMS lens and with bright light. So there are different ways of myopia control. So I think from now, the idea is to move on combining treatment, trying to improve the efficacy. So we just do it a step at a time, and so that we understand the principles are working first.
When we first started, our goal is a bit more humble, and it's not to compete. Not only not to compete with others, but really want to see whether the spectacle lens work as opposed to single vision. And we think that if it works, it will probably be helping people to change from single vision lens to a optical defocus spectacle lens. I think that was the first objective. And of course, there are a lot of talks about comparing different treatment modalities and even combining them, whether there are additive effects or not. So those are the things that we think would be a timely question to answer now.
Yes.
Yeah.
Yeah, very good. And also, I'm just thinking, because in your enrollment criteria, the patient you enroll there, most of them, they're just school myopia. They're not necessary to be progressive myopia. So it may not justify myopia control like ortho-K or even, the atropine control, because they're not progressive myopia, essentially. Mm-hmm. So that could be another consideration for, like, for example, not comparing DIMS with the existing myopia control strategy, if you agree to. But then I really appreciate the way that Chi-Ho comments on that you're not trying to competing with the existing treatment, like treatment method, like orthokeratology and low dose atropine. But can I be more aggressively, like, to mask? So do you think this would become a competitive product at the end of the day? And how this might change the landscape of, like, this myopia control strategy or business?
Maybe I say a few words first, and Kylie, you can supplement. As I said earlier, in the early days, it took us a long time to actually translate that into a product. First of all, we did it through a contact lens. And through that, we proved the principle that optical defocus seems to actually work in human as well. And that was a gap between the contact lens invention, so to speak, and the spectacle lens. And because we were thinking about, there are a lot of hurdles that we think we might encounter in putting a spectacle lens. Although we really want to make it a spectacle lens because it's easier to wear and so on. But it turns out that it's okay to cut a very long story short. That spectacle lens, the DIMS can produce such a good effect. And I think it would be up to patients' choice and also practitioner to recommend. I mean, in situation of patients are very different. And I think to me, if for a normal population, a spectacle lens would certainly be a very good option to start. And that's exactly why we think about how to incorporate the optical defocus in the spectacle lens in the first place, because we think it would be a bit more popular and easy to wear instead of using eye drops or instead of using contact lenses. And that is what we in the field know, that the first choice always a spectacle lens. So I think in the long run, unless there are other modalities get proved to be significantly better in efficacy, I think spectacle lens will remain as a very attractive option if we can produce myopia control modality in that way. I think even in other technology, they can incorporate in spectacle lens. I think that would be the way to go.
Yeah, I also think that the current single vision lenses, the curve that they use in the manufacturing is actually promoting myopia progression. So there have been papers suggesting that if you just fit a normal single vision lens at the mid-periphery to the periphery of the retina, there will be hyperopic defocus. So just opposite to myopic defocus, hyperopic defocus will promote eye growth. So I foresee maybe in the near future, nobody will fit single vision lenses anymore, but they will go on at least one of the choices of the myopia control treatment.
Yeah, that's very ambitious. Yeah, thank you for the answer. And I think this is very interesting because I think spectacle correction is always easier, much easier than contact lens. I mean, and also putting drugs in the eye every day before sleep. Can we just review a little bit, like what would be the recommended indication for DIMS treatment? So because, for example, for atropine or also keratology, we have an indication like progressive myopia, for example, early onset, or this. Yeah. So what would be the recommendation? A normal, like a minus, like for example, -3 diopters, 13 years old, would justify DIMS spectacle correction if they can afford to. I mean, obviously.
Yeah. Well, I would recommend to prescribe DIMS lens at any age with myopia. So if they start at 6 years old, then they should be fitted. Because if you look at the third year paper, the annual retardation is about 0.18 diopter. So if you want to claim all this effect, then you should start early. Because we are working on a population that is just normal children. So they are not fast progressors. They are not considered high risk, but just a normal group of young children. So from that data, then I would suggest that, if a child starts to have myopia, then they could use DIMS as a myopia control method.
Yep.
Mm-hmm. Yeah, I agree too. Although some practitioner will be hesitant to say, well, this child has only a very small amount of myopia. Should we start any treatment? But in Hong Kong, I think we do have a strong evidence to show that once they have myopia, when they go into school age and their study intensified, and you more or less see a straight curve of myopia progression up to 14, 15, or 16 years old. So there is, at least in the Asian population, East Asian population, and this curve applies to, I think, 99% of the kids. Once they have a myopia progression demonstrated, they will go on to have very, very fast progressions when they go into school age. And in the study that we have, once they were the DIMS, and we don't see much contraindication or side effects. So I think it's like a preventive measure. Even if you have a kid's young age having myopia already, I think I would certainly recommend them to try DIMS or any other myopia treatment method to slow it down. You never know, because there's no way back at the moment. Once you develop myopia, there's no way back, and the risk of having other ocular complication increases with the degree of myopia. So I would certainly recommend it as much as possible. We will try to put the treatment in the first instance.
Very good. So going back to the study design per se, for example, in order to demonstrate the effect on myopia control, some of the clinical trial they use psychopicture refraction as a primary outcome, and some use axial lens elongation as an outcome. In your clinical trial, actually, you choose to use both of them. The primary outcome is psychopicture refraction, and the secondary outcome is axial lens elongation. But then in other clinical trial, for example, orthokeratology clinical trial, for example, they may not able to demonstrate effect on the axial lens elongation, myopia control effect. So can you comment on the rationale for choosing psychopicture refraction and also adding axial lens as an outcome, and also how do you interpret the effect in both psychopicture refraction and axial lens elongation?
Yes, so refractive error and axial length are highly correlated. So they are measuring like the same thing. That for any myopia progression, it will reflect in the axial length elongation. So we do both is because for clinicians to understand the concept, and also for the layman like parents, refractive error is still the most popular choice. So that's why we think that the psychopicture refraction is something that clinicians can convey and communicate with parents much easier. And at the same time, axial length measurement is not always available in the clinical practice. So we can use axial length as a parameter to define the myopia control efficacy. But then if we use it as a measurement parameter, then clinicians that do not have a biometer would have difficulty to convey the parents and the child. So I think we do both is because that we found that axial length has the value that it indicates whether there are stretching of the retina, so enlarged eyes. So axial length is representing how big the eye is. So enlarged eyes would have a lot more chance of developing retinal pathologies and changes.
So Kali, so in your understanding, if the treatment or whatever methods demonstrate they can control the psychopicture, the refraction progression, myopia progression by psychopicture refraction, but not in the axial lens elongation. So do you think this is still like a meaningful, effective myopia control? So
I wouldn't think so, because the axial length is where the whole purpose of myopia control is to prevent ocular pathology, to prevent an enlarged eye that would likely have a retinal hole, tear, or detachment.
Fantastic.
Yeah, I agree. There are many purposes. As you said, some of the paper stress on the refractive errors rather than axial length. I think for our study, we want to catch all, really. And to show that in both, it's good to see our data that correlate quite well. In terms of the treatment effect in the refractive error and also axial length. I totally agree with Carly that axial length would be, for a scientific study and also in a long-term view, the ability to control axial elongations is more important to prevent the ocular side effect, because we know that it all coming from the stretching of the whole eyeball with the anterior or posterior eye. So controlling axial elongation from the healthcare perspective, it's even more important than refractive error. As such, you said sometime for example, in atropine, you used to see a refractive error retardation, but not in the axial elongation in low dose atropine. So a number of studies show that already. Yeah. So likely that some treatment effect has the effect of changing maybe a refractive component rather than the axial elongation. So when the clinician consider treatment modalities, they need to look at those data. I mean, if they are to they want to control elongations, want to control side effect of myopia, I think those the axial data will be crucial.
Fantastic. So from the research design or study design point of view, so can you explain a little bit why you consider to run a 3-year study? I mean, to prove, what is the additional evidence or benefit to running this the 3 years study and public? And because when we didn't able to demonstrate rebound effect, I mean, like stop treatment, but then it perfectly demonstrate the continuous treatment effect and over time, and also a lot of other information. So can you explain it very briefly? Yeah.
In the beginning, when we want to test the DIMS lens in RCT, we consider the time that we have results to look at. So we thought 2 years would be good enough, because most RCT will accept 2 years results. And so we set it as that. And then at the end of the 2 years, we found that, there are quite positive findings, and we can control myopia quite well. And then there was the dilemma whether to go on the 3rd year as RCT or not. But then in the beginning, when we recruit subjects, we have to provide them an information sheet and consent form. But at that time, we told the parents and the children that we will run it for 2 years. At the end of the 2 years, if the results are positive, then we will offer this treatment to those children in the control. So it is fulfilling this promise that when we consider, we want to see the sustainability of the efficacy, and we also want to benefit the children that have participated in the study. Therefore, we run it as just a follow-up study. So the children in the DIMS continue the 3rd year, and children in the single vision group switch to the DIMS lens. So we were very pleased, because on the 3rd year, all the single vision group had benefited with the DIMS lens, and their myopia control was quite good too.
Fantastic.
So it saves time, so we don't need to run the 3rd year, and the children benefit in the single vision group.
Yeah, it was also very good to see that even we don't have the 3rd year RCT data, but if you look at, we compare the historical progression data in the usual population, you can see that both in terms of axial length retardation and refractive error, the treatment effect remains. So as you know, that some of the treatment effect sort of decrease with time. So it's pleasing to know that DIMS effect seems to be holding up quite well, even going to the 3rd year. And we are now looking into the 4th and the 5th year and see whether the effect's still there. Because it's going to be a long-term treatment for children, it's important to see the effect, a long-term effect as well. I want to say something about the rebound effect, and we talked about that too. I mean, in some study, a number of studies that they do look at rebound effect. I think for a spectacle modality, the need of looking, I mean, it's a strong. There are strong evidence that if you don't treat it, it will rebound, in many cases anyway. So there are evidences to show that it will rebound if you don't treat it. So that's not as urgent as a question that we want to answer. And also because in some of the modality, when you use drugs and when you use ophthalmology, there are considerable complications that you will worry about, and that's why you want to stop the treatment as soon as possible if you completed the treatment effect. But for spectacle lens, as I mentioned earlier, then the DIMS lens, we didn't see any complication whatsoever for the kids to worry, even when they play sports and so on. And we deliberately did not ask the children to confine the activity when they use the DIMS. They want to see the effect, whether this, we can't use it when we play sport and so on. We never have that kind of comments. So ideally, if there are no complications for children to continue wearing this lens, and they can conduct all kind of daily activities, and I don't see why they need to stop it. I mean, if they stop it, they will change it to a spectacle, a single vision lens anyway. So exactly the same. I think the risk that they're taking. So I think the rebound effect is less a concern in the DIMS spectacle wearing modality if it works.
Yeah. And I think Chi-Ho raised a very good point in terms of the visual quality when people wearing DIMS lens, because the DIMS lens, as far as I understand, the optical correction zone is about 9 millimeter. So theoretically, when you wear glasses like that, if you play around and sometimes you look peripherally with this, I mean, then when you look peripherally, so that would be, maybe you just look through this DIMS area. So would this affect people's visual quality, or have you collect data, such kind of data in the clinical trial as well?
Yeah, it is in the 2-year RCT paper.
Yes, actually.
And we also have published another paper that in another journal, and it covered the visual function changes at the beginning and after 2 years, after they completed the trial. And all those visual acuity at high contrast, low contrast, distance, and near, under different lightings, and also amplitude of accommodation, accommodative lag, they were insignificant statistically, comparing the two groups. So, so I think the lens has no adverse visual function effects at all, comparing to the group that are wearing the single vision lenses.
Yeah, very good.
Well, I should add that as Professor He, you were saying that when the kids looking through the region where you have the focus micro lenses, and there will be a slight decrease in vision. But when we look at the high contrast subject or object that they're looking on, the effect is very, very minimal. But in dim lights, and probably have an effect, because there will be 50% of the light will be coming from the optical defocus that might affect the vision a little bit. But then, as you said, we have a central zone of 9 millimeter. What we recommend them to do is, if they want to see things clearly, they get to change the direction of the head and then looking through the optical zone, and that will give you more or less a sight like a single vision visual acuity. So that helps.
Yeah,
the children learned very fast.
They can adjust very fast. Exactly. Yeah. So my final question is about what is the greatest challenge? I mean, when you run this or design and run such a innovative study in Hong Kong, what is the greatest challenge in Kong? I mean, looking back like 4 or 5 years ago.
Or 10 years.
Or 10 years. Exactly.
One thing, I say first, which actually took us a long time. The idea of using myopic defocus to slow down eye growth came out in 2002, and then we designed the lens and to do a animal study, and that completed in about 2003, 4 years, about 4 years you take, and then we changed it into a final manufacturer that able to produce a concentric lens. Or contact lens, and that took us about another 6-7 years, and then we stop. And because there is a challenge of incorporating optical defocus in spectacle lens, we thought about it, and this honeycomb design is just come to us all of a sudden, and because eye movement is an issue, so with that micro lenses display, we took away the effect of eye movement. So it took a long time to come up with this idea, and also this idea is pretty novel at the time, and the manufacturer has reservations. Put it that way. They said, "Oh, does it work?" I mean, and at the time, myopia was not such a big issue in the whole eye research field. So the contact lens didn't. We would talk to a lot of manufacturers; they are not interested, and then as the myopia population awareness increased with time, then the industry start to pick it up, and then when we talk to this manufacturer, and luckily they have the courage to take our wild thoughts and try to make the lens and then conduct the clinical trials. So it took a long time to communicate with many stakeholders and to convince that this is a way to go. We could have given up at many time points, so let's say.
At many
But
times.
I mean, yeah, but this is because we were convinced that this optical defocus method can work from our contact lens trial. We think it will certainly benefit our children. So at the time, there was no more, apart from atropine, there's no easy treatment, so I say, for myopia. So that sort of puts us to think deeper and try to seek out whoever can trust us enough to give it a go.
Fantastic.
Yeah. Well, actually, so it was Chi-Ho who bring up this idea with me, and then I said, "Oh, you want to combine two focus together and as a myopia control? I think it is workable, but then it has this kind of optics, so like a diffract lens." So at that time we were talking, oh, we should make something like a diffract lens, and that may work. But then there are a lot of hurdles, and in Hong Kong we do not have very good support in manufacturing of lenses at that time. So it was until that we thought about the contact lens option, and then we started to talk to a lot of industries. But it was a very distressful time for us, and also we are very disappointed because not many industries really interested in our idea. So at the end, we applied for a government funding to do the first project, and we were successful. So and it was such a humble project because we are not funded a lot. So we have to get a very good price for each contact lens. So it's a special made contact lens, so it's supposed to be more expensive. But we managed to work with a local manufacturer, and he gave us a very good price. So with that, we have our first BJO paper on this lens is also on BJO. And then from there on, we were more confident. And again, like Chi-Ho said, that when we want to translate this into a spectacle lens, is another hurdle.
Yeah,
and even when we talked to this conservative manufacturer, they said they could not guarantee any outcomes. But they said if they think of something, they will come back to us. And they gone, disappeared.
For a year and a half.
Yeah, so it was half a year later that they come back. They say, maybe we can make the lens. And then we had a meeting, and then we were very excited. I still remember the meeting that we have a whiteboard, and we wrote a lot of things on the whiteboard, and it is amazing. So it was from then that we started this DIMS RCT trial preparation. And so from then on, it's been very exciting. So the lens has been well received by the market, by the practitioners. So at the end, we are happier.
Fantastic. So I really want to say thank you now, because 30 minutes is very, very fast. It's really like 1 second. So I really enjoy our conversation, and I've been learning a lot. I'm sure the audience also learned a lot from your challenge, and also a lot of story behind this great success. And your project is really a perfect example, demonstrate how people the whole journey from innovative idea, and then running a lot of overcome a lot of obstacles, difficulties, and get the work done, and then finally translate this to be like a very innovative product that tackle a myopia, a huge problem, in particular in the East Asia population. So I just want to take this opportunity. Thank you very much again, Chi-Ho and Kali, for your great participation, and I wish you all the best for your future career and the next product. Thank you so much.
Thank you, Professor He.
Thank you.
Thank you.
Have a great day. Thank you.